Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are going to record another primary snippet in our new series. So welcome, Maddie.
Hi, thanks, Swapnil.
So today we are going to discuss very important topic. And this is another question that has been asked in primary, both written and Viva format. And a lot of candidates still struggling to pass this question, which is around the pharmacology of 4% albumin. So Maddie, can you please walk us through the pharmacology of 4% albumin?
Sure. So just in terms of structure, I'm going to talk about the presentation, the pharmaceutics, indications, pharmacokinetics, pharmacodynamics, and some of the adverse effects. In terms of the presentation, 4% albumin specifically is a clear, slightly viscous liquid. It says on things like MIMS that it can be colourless, but I've only ever seen it yellow. I don't know if there are other forms in different parts of the country that are a different colour. It comes in a single glass bottle with 3 different sizes available. So there's 2 grams in 50 mils, 10 grams in 250 mils, or 20 grams in 500 mils. I've only seen the 20 grams in 500 mils in used, but I think in places like, say, pediatrics, they might have the smaller vials. In terms of the pharmaceutics, it's a blood product. So it's manufactured from donated human plasma using mainly chromatographic techniques. It is preservative-free, it's sterile, and it's iso-oncotic with human serum. And it contains about 40 grams per litre of human albumin, as well as about 140 millimoles a litre of sodium, 128 millimoles a litre of chloride, so quite a bit of chloride, and 6.4 millimoles a litre of tannate. It has an osmolality of about 260 milliosmoles per kilo and a pH of between 6.7 and 7.3. It contains no antimicrobial preservatives, so it should be used immediately after opening the bottle. In terms of the indications, this is still, I think, a work in progress, but it can be used for fluid resuscitation. There's obviously the ongoing debate about the utility of crystalloids versus colloids, but it's often used as parts of burns resuscitation, especially in what we sometimes term difficult burns resuscitation, where they're needing a large volume of fluids. Also sometimes used in fluid resuscitation if there's concerns about volume overload or if there's a significant volume of crystalloid already given. It can be used in fat embolism and also for cirrhotic patients or in hepatorenal syndrome. And it's also used in volume replacement in terms of for plasmapheresis, for large volume paracentesis, and sometimes in post-operative cardiothoracic patients. In terms of the pharmacokinetics, this is all extrapolated from just normal human albumin rather than studying 4% albumin specifically, but it's administered intravenously. It's not given orally, obviously. In terms of the distribution, it follows the same thing as total albumin. So the total albumin within the body is usually 4 to 5 grams per kilogram, of which 40 to 45% is intravascular and 55 to 60% is actually extravascular. And these percentage can vary depending on the permeability of capillaries. So things in conditions in the critically ill that result in increased permeability, such as things like sepsis, you might have an increased percentage of albumin that goes into the extravascular compartments. In terms of the elimination, the circulation half-life is about 16 hours and the elimination half-life is approximately 19 days. And it's mainly eliminated intracellularly through lysosome proteases, which degrade it into amino acids. Coming to the pharmacodynamics, so from a cardiovascular point of view, it helps to maintain the plasma colloid osmotic pressure. So hopefully, therefore, if you do transfuse it, it's more effective, or the theory is it'll be more effective in expanding the intravascular volume, as hopefully more of it will stay in the intravascular space. It also is thought to have a significant role in protecting the glycocalyx, and the glycocalyx is something that contributes to the endothelial barrier integrity and is important for regulation of vascular tone and inhibition of leukocyte adhesion. So increased albumin is thought to help protect this. In terms of metabolic functions, it transports multiple drugs and hormones, so it can affect the half-life and serum levels of certain drugs. For example, low albumin levels can increase your phenytoin level. It's also a weak acid, and it comprises the majority of total extracellular acid in human plasma, and it's a negative acute phase reaction protein. So you'll see often in the critically ill, their albumin levels do go down. And it also has immunomodulatory effects. So it protects the endothelium and reduces endothelial dysfunction. It modulates arachidonic acid release and protects against ischemia and reperfusion injury. And it inhibits apoptosis triggered by oxidative stress by scavenging reactive oxygen species. However, as a blood product, it does also have adverse effects. So you can have allergic reactions, and you're more likely to have allergic reactions with like albumin compared to a lot of the crystalloids. So this can be mild with nausea or urticaria, or can range all the way up to anaphylaxis. It can cause hypotension when infusing, and it might worsen the mortality in traumatic brain injured patients, which was just a subset of patients seen in the SAFE study, but this was like secondary, wasn't a primary outcome. It can cause fluid overload, and there is the theoretical risk of disease transmission because as a blood product, but this is lowered due to infectious screening of plasma donors, and also because they use quite stringent viral inactivation and removal procedures for albumin.
Thanks, Marty. So actually, I was just researching why albumin has got a yellow color or yellow-green color. So it's very interesting. The albumin is derived from the ethanol precipitation and has got undetectable levels of bilirubin. And usually the amber color of this product is attributed mainly to residual heme. And the presence of bilirubin during the pasteurization process leads to oxidation of heme to biliverdin. And that's why we get a color change from yellow to yellow-green. Now, this property, and this is very interesting because the yellow color of albumin is due to its pH. At pH of 3.8, it kind of stays yellow, converts to green at a pH of 3.8 to 5.4, and then subsequently it turns into blue at pH above 5.4. And same property is actually used to measure serum albumin concentration using the agent called as bromocresol green. So what they do is at acidic pH, albumin forms a color complex with bromocresol green, which can be measured at 630 nanometer wavelength. So I thought that's an interesting trivia, why albumin is yellow. Thanks, Maddie. So we'll be back with another snippet in week's time. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.